Dr. Don Clary is the director of the Indian Health Service's Joslin Vision Network Teleophthalmology Program and National Reading Center, in addition to her role as the chief clinical consultant for optometry. She is interviewed for Vision 2020 USA's Telehealth interview series by Cristos Ifantides, Director, Ophthalmic Global Outreach and Assistant Professor of Ophthalmology, University of Colorado, Denver, and Vision 2020 USA board member.
Hi, everybody. My name is Cristos Ifantides. I'm an ophthalmologist in Denver, Colorado, and I sit on the board of Vision 2020. Today, I have the privilege of interviewing Dawn Clary, who is a doctor of optometry. She received her degree from Pacific University in Forest Grove, Oregon. She is the current director of the Indian Health Service's Joslin Vision Network Teleophthalmology program, and also the director of their National Reading Center. And so we're honored to have her here with us today to chat about her work that she's doing. And so first and foremost, I want to thank you for joining us and taking time out of your busy day to speak with us. And I guess we'll start by just asking, can you briefly describe to the audience your path to working in the IHS, the Indian Health Service, what your role is in there, and specifically how you began your journey into telemedicine for eye care?
Okay. I actually am the chief clinical consultant for optometry, along with the other hats that you mentioned, director of the IHS JVN Teleophthalmology program and the National Reading Center. I started my journey into telemedicine, I think you'd have to say as an intern, as a student at the Gallup Indian Medical Center on the Navajo Reservation, where we would receive Polaroid pictures of the back of the eye for our patients who are out in remote locations on the Indian reservation, and they would mail these pictures of the posterior pole to us at the Gallup Indian Medical Center, where we would have a meeting probably once a week, and we'd go through every photo and decide pretty easily, maybe like a category 2 program. We would say this patient has diabetic retinopathy, and then this patient does not, and then you take the patients with diabetic retinopathy and split them up into, do we need to bring them to the Gallup Indian Medical Center, or can they be followed? So that was kind of my first step into basic telemedicine in a way. And then when I was finished with my tour in Gallup, and I transferred down to the Phoenix Indian Medical Center, where I've been for the last 24 years. So I came into Indian Health Service right out of optometry school, and it's been a fantastic career. I definitely enjoyed a lot of the Native American experiences that I've had. And when I came to the Phoenix Indian Medical Center, there was a program just getting started with Dr. Mark Horton, who is a OD-MD, and he actually started the IHS JVN Teleophthalmology program, and kind of brought me in because I really had a passion for diabetic retinopathy, and this really interested me, and to this day I still really enjoy looking at those photos. But after a few years of reading with the program, I became the director of the Reading Center, which is here at the Phoenix Indian Medical Center, and we now have a staff of 4 optometrists and 2 JVN imaging technicians, and then a program assistant. So we're still very small, but this is the program that we have now. And we have gone from 1 camera here at the Phoenix Indian Medical Center and 1 satellite clinic, which is the Salt River Clinic about 17 miles from here, and have expanded now into 158 sites across the United States, whether they are federal, urban, or tribal. As long as they take care of Native American patients, they are eligible to have a camera. And all those images are digitally transmitted here to the National Reading Center, where we read and we give them a level of diabetic retinopathy, a treatment plan, and a follow-up. And our program started back in 2000, and it has been expanding ever since. And we've had some programs drop off due to several issues or whatever is going on, and more sites now coming on board. And so when it comes to the number of cameras out there, there are a lot more out there than than facilities that are imaging. So it's been wonderful in that we've been able to expand access to care for our Native American patients and their diabetic eye care.
Yeah, that's really impressive to hear over the last 20 years from going from mailed-in Polaroids to
Yeah,
reading centers, over 150 of them. Um,
right.
could you mention for the audience, for me, I'm always intrigued about what it takes to set up a site and sort of the prep work. In our Safety Net hospital network, we're trying to do the same. And so from your standpoint, it's more than just a camera, right? So what sort of ingredients, sort of what makes the right soil for a location?
Oh gosh, there's kind of a variety, at least for us. No one facility is perfect, and they're never exactly the same. So we have to be very flexible with what we do. So the first criteria for our JVN program is to have a Native American population base of diabetic patients. And we used to have to have a minimum number of diabetic patients within their registry, but now with the funding that we get from the Indian Health Service and headquarters, we really don't have a line anymore. So they can have 12 diabetic patients and still qualify for our program and to get a camera. So what we do is a site will contact us, and we do have a website out there. Just have to Google IHS Teleophthalmology, and our program pops up with all our contact information. So they contact us, and we have a few questions. They have to be able to provide space for the camera, and really that is difficult. Space is at a premium in most of our facilities, and we do need to have at least a 10 by 10 room that can be dark adapted and to be imaging for them. There needs to be connectivity, which is also an issue. If they don't have a reliable internet service, it makes it very difficult to transmit these images. But we still work with them and have the ability to wait for those images to show up. So it doesn't stop them from becoming part of our program, but connectivity can be an issue. They have to have dedicated staff that we need to train to be an imager for their program. So a lot of times facilities have identified staff to be trained, and we train them, but these are other duties as assigned. And so if they don't have the dedicated time to be on the camera, then they lose their proficiency, and it gets difficult when they're sending images that are ungradable. So we always work with them and make sure that we can identify a staff member at their facility that can take these images. Once that has been worked out, then we need a memorandum of agreement between the Indian Health Service and that facility, depending on if they're federal, urban, or tribal. And we go ahead and we supply for our program the camera, the computer, the table the camera sits on, and all the software. And then we take care of all the technical support for this program. So there's no out-of-pocket cost for these facilities. The only thing that they have to supply would be the space for the camera and the staff to image off of the camera. So it's
Wow.
It's very good. I mean, they can bill for the imaging
Sure.
themselves, and they can actually go ahead and pay. It can end up paying for their salary for a staff to image. And we read all the images here at the National Reading Center, and we return those reports directly to the facility. So it's a bi-directional.
Wow, that's fantastic. Great. Well, thanks for sharing that recipe for us.
Mm-hmm.
Telemedicine has become prominent in both the news, but also in more than just eye care. Is there a particular strength for eye care that you feel puts us as an advantage compared to other fields, or what has it allowed us to do really over the last 30 years that we weren't able to do before?
Well, specific to our program with diabetic retinopathy, it has allowed us to get into places that have never been able to get eye care. And so that increasing access to care and timely access to that care is important. There's a lot of patients in remote areas that we have trouble accessing, especially in remote Alaska and those areas. Our cameras are up there and are available to take care of those patients. But I do feel that we're not where we should be with telemedicine. I think there's a lot more that we can do out there. But we have our obstacles, you know, we have our speed bumps, and it gets difficult to talk to those elderly patients maybe who are a little nervous about technology. And then, you know, again, it's getting the facilities to buy into the telemedicine programs. And you know, I think there are many times where I have talked to programs where they want to know how much this will cost. You know, you don't get something for free. But seriously, our program is at no cost. And that's been kind of a speed bump for us to get over. But once we get there, things do very well. But again, telemedicine is advancing, and that's what we need. We need to be able to get it out there.
Great. Yeah, so it's can be quite clear when you're talking about reaching very remote areas, how vulnerable populations, marginalized populations can certainly advance leap and bounds in access to care and getting the care they need compared to waiting for somebody to visit there in person to do that care. So from an outreach perspective, you really can see the power of tele-eye care. So do you believe that there are issues with adoption within certain type of practice? I know you talked about space, and then you touched on elderly. Can you delve into that a little bit more? What are some of the barriers you've experienced in terms of just having people adopt the technology, and what strategies you've done or you've incorporated, whether it's just educational campaigns? Is there something that you focus on more than others, like the cost thing, how you approach that with the groups to get buy-in from both the organizations, but also the patients?
Before COVID, it was a little bit easier in that we could go to the meetings and meet with tribal elders and their boards and discuss with them along with the primary care doctors, because our program is actually a primary care tool, not an eye clinic tool, although we are very, very closely related and we're intertwined with the optometrists and ophthalmologists. We really need the primary care teams to help us grab those patients. So what we found in the past is the Indian Health Service as a whole was not even seeing or providing the standard of care for our diabetic patients, which is the yearly eye exam. And so when we found that increasing access to care was the key, where do we put that access to care? So we found that if we put it in primary care clinics, then those patients are showing up to primary care, they're showing up to pharmacy to pick up their medications, and they're actually even going to podiatry to get their feet examined, but they weren't coming to the eye clinic. And so trying to put a camera in a primary care clinic is odd. It's odd for the primary care practitioners, and it looks weird. And they just assume this should be in the eye clinic. So that's been something we've had to deal with also. Primary care doctors have been fantastic once they understand what we're doing and why we're doing it. So education is absolutely the key, but not only for the primary care providers, but for the patients. In the past, I think, as I've been in optometry for over 26 years, and many times you have a pamphlet or a piece of paper that has a drawing of the back of the eye, and you're trying to explain to your patient, you have this, but it doesn't look like that, and it's over here. And it gets very confusing to the patient. And so especially when you're talking to an elderly patient who maybe in our population doesn't speak English very well, that's another gap. So if we can turn our computers around, our camera tablet, and show them exactly what the back of the eye looks like, these are things that help in the education, and it brings to light exactly what's going on with that patient and their diabetes care, as a whole. Some of the other issues, we talked about connectivity, but technical assistance has been difficult in some of these places. Not only the connectivity technical issue, but qualified people to image and use the technology that we have out there. And I think we kind of pride ourselves here on that. We can pretty much train anyone to take a picture, but what do you do with that picture is important, and the education for the imagers that we train, and we train in-house now. They used to come to Phoenix for 2 to 3 days for training on imaging patients and patient education. And now we do this remotely. I think because, especially because of COVID, we've had to step up and do that. But I think that's kind of the way that we're going to continue, at least hybridly, to train these imagers and to make sure that they understand that it's not just pressing a button and taking a picture and transmitting them. It's really about the patient. And so those are some of the issues that we work with. I get calls from tribal clients, tribal members, tribal staff and board all the time saying, why don't we have this? And so it's just connecting with the right people. Then that way, if we can't connect with the right people, it makes it more difficult. So once we connect, it's really an easy thing to do to get this to them. And we're working with probably about, I think as quickly as we can turn these cameras around and get them out there with all the paperwork that needs to be done, we can do this within 3 weeks.
Wow.
But the typical is more like 6.
Yeah, that's still very fast. If we're talking weeks and not months or years.
We've cut this down quite a bit. Yes.
Yeah.
And the technology is getting better, smaller, and easier to use. So I think that's where we're headed.
Yeah. And so do you have different camera types at the different sites? Is it sort of like the same brand of camera that you then update, or is it just sort of whatever you can get your hands on is what goes out to the sites?
No, actually, we have only 2 cameras that we use, and they're validated to the ETDRS, so the Early Treatment Diabetic Retinopathy Studies. And we only have 2 right now that are validated at a Category 3 telemedicine program. So we have the Daytona Optos, the ultra wide field, which is now our workhorse. And then our mobile camera, you can't really use the ultra wide fields for mobile because they're very sensitive. So we have a Centerview Aiden camera that has been just fantastic. I mean, the images, just HD quality. I'm very impressed with the quality of the images, but because it's not ultra wide field, we have to take more images than the Optos does. We used to have, our workhorse was the Topcon NW6S, but with that camera, we were having to take in so many pictures just to get the periphery that it was very hard on the patient. They would come out 22 standard images, flash photography, and they'd walk out with, purple spots in their eyes. And it wasn't very comfortable sometimes. So we've now gone to the Optos Daytona, where we take 2 of the right, 2 images of the right, 2 of the left, and they're done. So it's very nice. But those are the only 2 cameras that connect into our program. And of course, we are hoping at some point, maybe a handheld camera, just because of mobility and the ease of those handheld cameras might be something that we can have in our repertoire. But at this point, we only have those 2 cameras. So.
Got it. Yeah. So as a segue there, if let's say there was a bioengineer, optics PhD watching, what sort of technology, and it doesn't have to be camera only, it could be a clinic space, but what sort of technology do you think doesn't exist just quite yet that would really make this more impactful, make your job easier, reach more people, in case anybody's watching that could have the wheels start spinning for new technology they can help create?
I think for our program and our patient population, this is not new out there, but I think, need to move more towards AI. I think it would help us in, taking those normal retinas, the ones that don't have any diabetic retinopathy or pathology, and just kind of pushing them to the side and grading them where, we can get in and take care of those more acute issues that are going on. There was a time in the past that we were imaging and receiving so many photos, we were 5 days behind in reading, which could be about 600 to 700 studies. And every morning I would come in thinking, I have to get to that proliferative. I have to find that patient with proliferative diabetic retinopathy. They're in there, they're in there. And if I could just get a little bit of quick help to get the, the normals off to the side, I think that would be fantastic. We would increase our return times or decrease our return times. They would be much faster with our reporting. And those patients wouldn't be sitting in the list or in the queue waiting for us to evaluate their images. So I think AI is something that is going to be very helpful. It's definitely going to be one of the tools that we're going to be looking at in the future. And I don't know that we're missing anything. I don't think there are huge gaps, but just getting access to those for Indian Health Services is going to be our issues.
Yeah. Well, it sounds like potentially a handheld wide field as well could be.
Ooh, yes.
Yeah. If we're just dreaming here,
Right.
But yeah, that's really interesting. I think the AI, you bring up a great point because there's only so many hours in a day where a human being can be reading, and what do the studies show in terms of, after 10 hours, are you as good as 1 hour kind of thing. So if you could make every hour that you are looking at a photo higher yield by filtering out the normals, it certainly would improve access. So I know there are some companies that are pairing their devices with the reading service, but I think having people jump on this project with you to help filter out those normals and allow you to focus on more disease would allow a bigger expansion, certainly.
Right, right. I think if we get too complicated, though, right now they have the retinal photos, ultra wide field, along with OCTs, which I think would be fantastic to have, and would really kind of push towards that. But if you start adding too many pieces of technology, it could get a little more difficult to go through all the information. So I think in a way you can't have everything you want, but definitely the pieces that we could get to put together with an optometrist and ophthalmologist to review is going to be fantastic. We have, you were talking about how much time can you sit in front of a computer. Our staff here are trained, we're all optometrists trained in digital imaging and reading, but we only work half days. So we are in the clinic half a day and we read half a day. And we found that that's actually most productive. We can read more in a half day than we can actually read. If you even doubled our half days, we can't do that in a full day. So it gets tiresome. We have tools that help us with some of the reads, but yeah, I think that a little bit of help would be great.
Yeah, I'm always impressed with radiologists who are doing, 12-hour shifts in the dark.
Absolutely in the dark. So yeah, we're in the dark too, but we don't do the 12-hour shifts.
Yeah, that's a great way of breaking it up to keep the cadence up and the focus. So great. Well, so finally, just to touch on the future. So when you think about, 20 years ago, getting mailed in Polaroids and seeing the trajectory, it's tough to imagine that we would have reached, this point. And with COVID, especially accelerating, I would say this, synchronous or asynchronous medical care, where you can have even appointments with a provider, exams with the provider, or even asynchronous where you get the image. How do you feel now that COVID has come into our lives and money's being poured into telemedicine specifically? What do you think the next 10 to 15 years has in store for telemedicine, especially in eye care?
Well, I think that's where we're headed. And yes, like you said, with COVID, we were kind of pushed into really starting the telemedicine track, I guess. So where do I see us in 10 to 15 years? I don't see a full eye exam going totally telemedicine. That'd be a little difficult to do, but the pieces of it are going to be fantastic, and as we move forward, the images will get better, especially within our program. and the turnaround time's faster. But I think these are tools that we should always be using and that would help us. But I really feel that face-to-face connectivity with our patients cannot be lost. But I do feel that we're going to all have that connectivity via telemedicine with our patients, just a quick follow-up kind of thing, and we do that now. I just see that being, instead of 25% of our practice, I see it being 50, 70% of our practice. I was speaking with a colleague just recently about, when we first came in 25 years ago, how we were worried about our jobs and who's going to do what between ophthalmology, optometry, and opticians. And it's funny to look back now in that we all still have our jobs. We all still work together. And I don't think telemedicine is going to change that, but I do think it's going to bring us closer as a community in eye care, because we can share more. And that's where I see us in about 10 to 15 years.
Yeah, it's a great point that you just brought up at the end there when you have this concern about job security and everything. We sort of think about it in terms of today's standard of care, but 50 years ago, physicians were waiting for the cataract to be a 2200 cataract before taking it out.
Right, right.
And so the same thing. I mean, there's so many people who don't get eye care, even in high income countries, that there is not going to be a shortage of people who need eye care. And so hopefully the technology that you and your team are championing now are going to really be incorporated into more corners of our country, but also the world. So it'll be exciting to see.
I agree. Makes me not want to retire anytime soon. I look forward to seeing what's going to happen. So I thank you for bringing up these questions and letting me talk about our program here and increasing access to care to our vulnerable patients out in the middle of the reservations, or even here in the cities at the Phoenix Indian Medical Center in downtown Phoenix. We have a lot of patients who still can't access us. So.
Yeah, that's a great point. Denver has 50,000 Native Americans in the metro area. It is tough to figure out how to provide access, and sometimes it's doesn't work with the schedules or with transportation, everything to get them into a center screening area. So if they start thinking about folks in their community that would fit this model, is the best way to reach out to go to that website and connect with you through that in order to see if they could, if there is a program already started in their area, and if not, to get something started with you all?
Yeah, absolutely. Our contact information, my information is on that website. If you Google Eye Care Indian Health Service, my name will pop up, and we are absolutely available at any time. The emails are easy. It's first name dot last name at ihs.gov. So I would be don.clary at ihs.gov. I answer emails all the time regarding programs and hey, I'm an optometrist or ophthalmologist. I'm interested in telemedicine. Are there any openings, kind of thing? Absolutely. We love to be able to talk to people. And yeah, I think the best way is either to reach out via email or find me in the directory. That'd be great.
Great. Yeah, well, I'm sure we're going to have viewers who are both interested in getting involved and making sure that people in their community are taken care of. So, Dr. Clary, thank you so much for your time today out of your busy schedule, and really impressive work. And we look forward to seeing what you and your team are doing in the next few years.
Thank you very much.
Take care.